Good evening to everybody. On behalf of the Dubai Shoulder Course, my co-chairman and myself would like to welcome all the attendees and of course our guest of honor, the Egyptian Arthroscopic Society, for this co-joint webinar concerning multiple pathologies of the shoulder outside rotator cuff and instability. So in this webinar, we will be passing the 60 minutes or maybe 90 minutes talking about some common pathology that we face in the shoulder. I am honored to welcome the faculty today talking about biceps pathology, Dr. Hazem Farouk from Cairo, Egypt, followed by our two speakers who will be talking about the AC joint, starting with Dr. Mohamed Sobhy, who will talk about managing AC joint dislocations, open technique, and then going into the arthroscopic technique with my colleague and friend, Dr. Usama Saleh from Dubai, UAE, and ending this webinar with Dr. Machani, who will talk about adhesive capsulitis and how he solves this issue. I invite and of course, ask you to ask all your questions in the Q&A panel. Please do not hesitate to ask your questions. Of course, if you don't have any, I will be moderating the questions to our speakers. So it's my great pleasure to introduce our first speaker, Dr. Hazem Farouk, who will talk about managing the long head of the biceps, tenotomy and tenodesis. Please welcome.
Hello all, Ramadan Kareem. First, I would like to share my gratitude and thanks to our moderator, Dr. Ali, and of course, the president of the Egyptian Arthroscopy Association, Dr. Adel Hamid, for this kind invite to represent the EGAA in this nice webinar. Also privileged to be speaking along with Dr. Mohamed Sobhy, my big brother and my dear friend. And on the other side of the bridge, Dr. Usama, my dear friend, and of course, Dr. Machani. How are you all? I hope that we enjoy this talk. All participants, hello, and hope you digested the food well after this fasting, and we enjoy our talk. My talk, if you would excuse me, I would share my screen. So here we start. My talk will be about the long head of biceps. Actually, the long head of biceps, I consider it as the most important supporting role. It's never nominated for big awards. It's never had the charisma or having the front lines or the headlines and the front papers. But I believe that it plays a very important role in the whole story of the shoulder pain and shoulder pathologies. And I believe that the story is not yet complete without taking a deeper look at the biceps tendon pathology and problem. So that's why we're talking about the long head of biceps, because it is a really common source of shoulder pain. A very common source of shoulder pain, either on its own or along with other pathologies. So we commonly see it in association with rotator cuff tears. This is the most cases that we face, frankly and directly, crystal clear pathology of the long head of biceps when we do a rotator cuff tear or when we deal with slap lesions. But as well, it occurs as an isolated pathology, and this might be commonly missed, and it might be highly resistant to non-operative treatment, either physiotherapy, local injections. So I believe that it plays a very important role in the pathogenesis of pain in the shoulder, and I think that it should be addressed. Elsewise, it would cause the patient to suffer from pain long time, even if we did manage his rotator cuff problem. If we did not address the pathology of the long head of biceps, he will still suffer. So what kind of pathology are we talking about when we're dealing with long head of biceps? Pathologies include tears. We might look for tears in the long head of biceps, subluxation out of the groove, tendinitis, and it's commonly faced with, especially with problems with the shoulder and rotator cuff problems, and high-grade slap lesions and biceps attachment injuries. So all this array or this spectrum of pathologies we should be aware of in order to start addressing it and deal with it as it comes. So first of all, I would start with how to clinically assess the long head of biceps. Before we go into the surgery, before we face this problem with long head of biceps and we are not sure whether to deal with it or not, as we're gonna say in our talk, we should be talking about how does the patient present if he has a problem with the long head of biceps. Actually, he is complaining of pain in the front of his shoulder, and usually this is differentiated between the normal shoulder impingement or supraspinatus tendinopathy pain that it extends distally until the elbow. It is exacerbated with overhead activities, and it is more localized distally rather than proximally, and this might give us a thumbs up in order to differentiate. It's not just a supraspinatus tendinopathy, it might be associated with a long head of biceps, so we need to treat it if we're going to treat the supraspinatus tendinopathy. Some tests might help us in order, although it is not specific, it's not really pointing out clearly to the long head of biceps problem, as well as the MRI as well. It might be misleading, sometimes effusion, so sometimes the pathology is not yet clear in the MRI and the clinical testing. But we have to do some provocative testing, tenderness over the bicipital groove, which is really could help us in order to be suspicious of any problems of the long head of biceps problems. And definitely instability, it's a yet more clear presentation when we hear an audible click and subluxation out of the groove with rotation of the shoulder. And that's why tests of the subscapularis integrity, which is commonly seen with the instability, should be performed as well prior to get the patient into the surgery. And this helps us a lot in order to know how to deal with the pathology later on. So this is a statement that we need to be clear about. If you are in doubt inside the surgery, whether it's the long head of biceps, is there a problem or not? I believe when there is no definite clinical or radiological signs or even arthroscopic signs of inflammation of the long head of biceps, I believe that always kill the biceps. This is the famous saying of the French school, who really accused the long head of biceps of a lot of things and a lot of pain. When we are doing a surgery for the shoulder, I believe that they always go for killing the biceps, and this is my philosophy as well. I have to address the biceps somehow. So if I am in doubt with no definite signs and I'm doing a rotator cuff problem or a rotator cuff tear, I believe I should do something to the biceps in order to avoid future complaints from the patients. But what to do actually if we're going to address the long head of biceps? If we are suddenly or accidentally faced with long head of biceps problem, if I am in doubt along with a rotator cuff problem, even if it's an isolated lesion and I highly suspect long head of biceps, what shall I do? So we have two things to be done here operatively. Either to do a tenotomy and to just cut the tendon out of the articular part near its attachment, or I do tenodesis. But what shall I do? Are there any clear lines when to do this procedure and when to do the other? This is what we're going to see right now by just skimming through the literature. Here is where we do the tenotomy, and this is do it near the attachment, and usually I leave it as it is, and it sometimes usually it is pulled into the groove and disappears out of the articular surface. If I'm doing the tenodesis, I have 3 points to do my tenodesis at: near the articular margin, and mostly it is done arthroscopically, or distally into the groove, and also this can be done arthroscopically or subpectorally, and this is done with a mini open procedure. So the tenotomy, what is the advantage of doing just a tenotomy for the patient that I suspect or I know that he has a long head of biceps problem? Definitely it's technically easy. It saves a lot of time and makes the rehabilitation fast. Even the return to the activity is faster with a complication and reoperation rate that is somehow low. So it is really an easy and beneficial procedure for the patient if he is complaining with a shoulder pain, and I'm into the surgery as well. So I have the tenotomy is a very, very good option, and it does not need a learning curve, or it does not take time. What about the tenodesis? What are the advantages when I do the tenodesis and why I do it? Definitely tenodesis preserves the flexion and the supination and the strength of the biceps. Definitely it can eliminate pain as well, and it avoids the famous Popeye deformity and the cosmetic deformity that happens to some patients when I do the tenotomy. Sometimes when the long head of biceps tendon slips into the groove, it causes this Popeye deformity in the patient's arm, and sometimes it is a cosmetic problem to the patient. So tenodesis avoids that. So when do I do this and when do I do that? What's better? Where is the more better clinical outcome? So I have to get back to the literature fast. So when I got back to the literature, I saw that regarding the Popeye deformity, there is a significant predisposition with the tenotomy groups. Definitely Popeye happens with the tenotomy groups, definitely more than the tenodesis group, and sometimes showed actually no difference between the predilection of the Popeye deformity with either group. And actually it is a complication that it is well tolerated. So by skimming the literature, I didn't reach a clear-cut solution or an indication whether to do the tenodesis or better to do the tenotomy. Regarding another complication that happens after dealing with biceps tendon pains, biceps cramps. Actually, in the previous literature studies said that tenodesis, 19% of the patient with the tenodesis groups complain of biceps pain and cramps. On the other side, more, 24% of the tenotomy group complains of biceps pain and cramps after the surgery. But again, some studies showed no difference. As well as the strength. When we compare the strength post-operative between the tenodesis and the tenotomy group, some studies showed no difference. Some studies showed that it decreases with tenotomy. So there is a very variable contradicting data when we skim through the literature or dig deep into the literature regarding the long head of biceps. And all the studies, not all, most of the studies are low-level studies because it is done retrospective, and even the few randomized controlled trials that has been published, it depends on the low-level studies, and that's why the previous systematic reviews have a limited value in order to guide us through what to do, whether tenotomy or tenodesis. But I came through this nice, really double-blinded randomized controlled trial that is published only in 2020, comparing both group anti-grade, and it showed that they both result in good functional outcome for both groups, the tenotomy group and the tenodesis group. And there was actually no significant difference in the patient-reported outcome, no significant difference in the elbow strength, but only higher risk of cosmetic deformity, the Popeye, with the tenotomy group compared with the tenodesis. And the choice whether to do or not to do tenotomy or to do tenodesis only depends on how can the patient tolerate, how much he can tolerate the cosmetic Popeye deformity that is potentially a risk to happen after surgery. So what do I do? Let's go and see how can I approach a patient, or how can I do actually the surgical procedure of tenotomy or tenodesis. And definitely tenotomy is a fairly easy thing to do. And I just need to cut the tendon near the attachment and just leave it as it is. But what about the tenodesis? Definitely there are studies, recent study emphasizing on where to locate the ideal fixation point of the tenodesis, whether to do it just beneath the articular margin or above the groove, suprapectoral, or just inside the groove, which is a little bit distally, arthroscopically, or I can minimize the complications and go subpectorally as has been said. So first, we're gonna discuss this arthroscopic proximal onlay technique to repair or to tenodese the tendon just distal or lateral to the articular margin, just above the groove. It can be done with a 30-degree or a 70-degree scope. And definitely it has multiple advantages. First of all, it preserves the length-tension relationship, because I tenodese the tendon before releasing it from the proximal attachment, and that's why I tenodese it along with the normal tension of the biceps muscles. And definitely this reduces the likelihood of muscle cramping and fatigue that is seen with tensioning, under tensioning of the tendon that can be faced with subpectoral tenodesis, and even minimize the risk of fixation failure when we over tension the tendon. And definitely it is, for me, much easier and much faster approach. If I'm doing a rotator cuff tear, it only takes less than 30 seconds in order to get done with the problem of the, not 30 seconds, maybe I put the anchor 2 or 3 minutes, less than 1 minute, it's the tenotomy, and 5 minutes I do the tenodesis. But I can go a little bit distally, and I can put my scope through the subacromial space and trace the biceps tendon as it goes into the groove, and I can tenodesis just inside the groove, or at the proximal edge of the groove, after I open the biceps tendon groove and I tenodese it there. And I can, that is advantageous in order to avoid the intra-articular hassle if I'm dealing with many sutures inside the joint, if I'm doing it on lay near the articular margin. The third technique, which is actually the mini open technique, it's a less than 2 centimeter or even 2 centimeter incision in the axilla, and I can get the tendon out of the articular part after I do the tenotomy first, and I mark it, and then I pull it out of this small incision, and then I suture it, as we're going to see later on with the technique, suture it inside just below the groove. This is just a quick video about the on-lay tenodesis that I usually perform, especially with the rotator cuff problems. Here is the scope entrance, and we will see right away the long head of biceps and how I can, this is when I mobilize it, and you can see the inflammation and the redness of the biceps tendon as it go down the groove. So I decided, of course, to tenodese it, and with the use of just the 30mm scope, just above the entrance of the groove, I put my tendon, I put my anchor sutures, and then I pass my suture around and through the biceps tendon in order to fix it in place, and later I do the tenodesis. Here is my 2 knots on lay, fixing it on lay just at the entrance of the groove, and I cut and I remove this part, the articular part of the long head of biceps, either with the diathermy as I'm doing here, or with a basket or a punch forceps. And then I go and remove the articular part near the attachment, and this articular part, I take it out of the joint completely. This is the first one, the first video I'm showing you, and there is another video as well to see again how I do it, this on-lay technique. This is a patient with a disrupted anterior pulley of the supraspinatus, and here you can see the long head of biceps tendon. And you will see in just a second how it is inflamed as it goes near the attachment, near the labrum, near its attachment. So this, the inflammation along with the disrupted anterior pulley made me take the decision in order to tenodese it in this young patient, 42 years old patient. And just using the 30-degree scope, just above the groove, I put my anchor tendon and I tenodese it as I did in the last case, as you are gonna see. I pass it usually first suture, pass it through the tendon itself at the same tension before I detachment from the proximally, and I pass my suture through and around the tendon, and then I suture it down to the groove, and then I cut as you saw in the last case. Here I'm tying the knot over the tendon. And then I'm gonna, this time I'm using a basket forceps to do my tenotomy just near the labral attachment. And as you can see, it is well fixed in place, preserving the normal length and tension relationship. And then I remove this articular part with either a basket or a shaver, and I proceed with my procedure of the rotator cuff. Okay, or if some patients, as you're going to see in my algorithm in just a minute, you will see how I do the mini subpectoral tenodesis. And I think it's a fairly easy procedure as well. Here is my incision. There where I start my skin incision. I go between the pec major and the short head of biceps. Lower border of pec major above, lateral border of the short head of biceps, and here I'm faced with the groove, and you will see the long head of biceps. I can roll it with my thumb, and then I take it out, pull it out of the articular part after I did the tenotomy, as you're going to see in a second. That was a young patient, that was a doctor as well, with a partial rotator cuff, or a small complete rotator cuff tear. But clinically, I suspected this long-headed biceps because he had a distal type of pain that is relentless. We tried conservative management for months and months, and we couldn't do it. So I took the decision pre-operatively to deal with the biceps. And because he was athletic and doing some kind of athletic or gym weightlifting training, so I decided to do the subpectoral tenodesis approach. I drill the tunnel and I use a tight rope in order to fix my tendon around it. As you're going to see now, this is an adjustable loop, whatever it is. And then I suture my tendon around the loop like this. And then I pull it inside. This is where I will, this is the guide wire. And then I pass my sutures and I make sure that it is directly passing into the groove, and I tightened it. So what is my algorithm in management? What do I do actually? When do I do a tenodesis? My philosophy, my approach, despite the fact that it's not really this algorithm, not supported by literature, it's out of my experience. And I'm yet to collecting the data for a large group of patients, comparing between the two patients in a randomized controlled trial as well. But this this is just a philosophy and not based on numbers or results. So the age plays a very important role in my decision. Less than 50, 50 to 60, and more than 60. The patients were less than 50, I always tenodese these patients. When it is an isolated pathology, I do a mini open subpectoral approach, and what is accompanied with, associated with the rotator cuff tear, I do an arthroscopically proximal onlay technique. With the gray zone area between 50 and 60, I have multiple options and take the decisions case by case. I can do a mini open subpectoral tenodesis if he is male and active and athletic, with either isolated or with rotator cuff tear. But I can go with the proximal onlay tenodesis if he is male and isolated with a slap lesion, for example. And I can make sure that tenotomy is enough for female with low demands. But I always do tenotomy in more than 60 cases, and I warn my patient that pop eye and deformity might be a problem and sometimes cramps, but usually in the old age, they are happy and well tolerated by the patient, these complications. This is my algorithm, and this is my final talk about, or final say about the long head of biceps tendon, and I'm ready to have your questions and have your experience as well to guide me and counter argue with me about this long head of biceps. Thank you very much.
Thank you, Dr. Hazem. Thank you very much for your talk.
Thank you.
It was very clear, very nice, nicely illustrated with clear thoughts that would help our audience understand biceps pathology. Most of us, I think, agree on what you are doing, as it is what we call the most common practice in shoulder surgery today. So first of all, I would like to announce to the audience that due to a prior engagement, you have asked to leave this webinar a little bit early, and we have decided to take the questions regarding biceps pathology now, and then move along to the next subject straight away. So I run directly through the questions we have in the Q&A panel. We have 3 questions coming from the audience, actually 4 questions now. Starting with, what do you do in chronic long head of biceps tenotomy? Do you think that ultrasound guided platelet rich plasma injections help?
I believe that it might help, but on a temporary measure. If it is isolated, if the pathology of the long head of biceps is only isolated, I have to do or to play all my cards before I get patients into the operating room. So platelet-rich plasma is an option. Even corticosteroids for once is an option to me as well. Ultrasound guided makes it more accurate and makes me sure that the patient got the maximum benefit out of the procedure, if any. So yes, I agree about it if it's an isolated. Definitely if it's not, or he has another associated problem, then there is no role for PRP.
Okay. Question from the audience is asking, do you have limitation of motion after tenodesis?
Actually, I don't have limitation of motion at all, but I have sometimes pain. Actually, I believe that the on-leg proximal insertion or proximal tenodesis that I usually do, I face not small number of pain of, you know, they say that there is somehow something is fixed inside my shoulder, but it does not limit the pain, definitely limit the motion, definitely, but they feel it, and for a long time. If I'm lucky, this will decrease by time and the stretch of the tendon itself help. But if I'm not, they still suffer from you know, a kind of pain after the proximal tenodesis. But if I do the subpectoral, usually the patients are happy with it.
Thank you. Okay, next question comes from the audience. How do you manage proximal rupture of biceps? Do you leave them or do you repair them?
Actually, the patient will let me leave them. Actually, usually the patients that suffers from long-standing biceps inflammation, long head of biceps inflammation, usually come and say that the pain is gone once they burst or once they detach from the proximal insertion. And I believe that very, very little amount of people or very small number of people will allow me to correct it cosmetically. But as literature said, and as with my experience, it is well tolerated, this pop eye cosmetic deformity, and I haven't done it after rupture. The patient just complain. I try to fix it back into the subpectoral just below the groove. I didn't do it before, and I believe that it is well tolerated, and usually the pain disappears after bursting or after rupture of the biceps.
Okay, I'll take the last question from the audience, sorry, and then, so how do you manage a tenotomy in rehab and a tenodesis in rehab? What do? Do you immobilize, no immobilization? Please tell us.
Actually, I start the Pender's exercises on day 1 post-operatively, and I proceed with the same protocol of rotator cuff tear, maybe, or even I don't do impingement on its own now, but with the rotator cuff tear, it usually does not change my protocol of management. There is no actual something to be cautious about, even when I do the tenodesis. So I start Pender's exercises and start range of motion on day 1 post-operatively, and I proceed after 2 weeks with starting the strengthening, static, and then dynamic, and then proceed with the normal protocol. It does not, you know, have any constriction or restrictions on my protocol to do the tenodesis or the tenotomy. It's more or less the same, but I have to be ready with the patient complaints that they complain more with the tenodesis. Okay. And I would like definitely to have the faculty opinion about that.
Yes. So my next question is, please, can all the faculty turn on the cameras and mics? Please join us, everybody. So I have a question for all the faculty. Please, we'll go through one. And we now know very clearly the thought of Dr. Hazem before he goes. I want to now ask the faculty, each one of you, passing from Dr. Usama, Sobhy, and Dr. Machani, please tell me what is the percentage of tenotomy versus tenodesis that you do in your practice, and if you do a tenodesis, do you do it upper, supra, or subpectoral? Please, 2 questions, 1 minute each. Starting with Dr. Usama. Shoot.
80% tenotomy, 20% tenodesis. I do it in the lower part of the groove.
Okay, Dr. Sobhy.
Suprapectoral, I mean.
Maybe I am doing the tenodesis and tenotomy. Maybe I'm treating a lot of athletes, so I'll usually I do tenotomy as Dr. Usama, maybe 70%, 30% tenodesis. Tenodesis, I prefer to do it in the groove with a screw, not on lay. But sometimes with athletes with spontaneous rupture during training, the tendon is slipped into the arm. So usually do a subpectoral tenodesis in such cases, but maybe 5%, 4% of the cases of the tenodesis.
Okay, Dr. Machani.
So I do tenotomy in middle-end sedentary patients associated with rotator cuff tears. And tenodesis, I used to do arthroscopically, but now in younger patients, I do mini open subpectoral. I just feel it's most secured, and I've gone away completely to do arthroscopically. I mean, my understanding is you take so much precaution and a lot of sutures to do subpectoral, but when you're doing arthroscopically, you just put one suture and then you're happy. I don't feel comfortable. They have a lot of re-ruptures on that one.
Okay. Thank you very much. I think for the biceps, we need the whole webinar, so I'll cut it short. It's been 30 minutes. We've passed enough time. So let's move on to the next subject. Please. Thank you very much, Dr. Hazem. Thank you for your time. Thank you, Dr. Hazem, for your time.
Thank you so much. Lovely.
So now we're going to move on to the next subject, please. Now it's the AC joint. It's a hot, controversial topic. Of course, this also needs a whole webinar to talk about, but we will just go and tackle 2 subjects today. And it's mainly about technique. Of course, I ask Dr. Mohamed Sobhy to start the webinar, the talk about AC joint open repair. Thank you.
Yeah, I manage the AC dislocation with the open or mini open technique. Before jumping into the subject, let me acknowledge and mourn Dr. Izzat Kamel. He passed a couple of months ago. He's my mentor. He is the knight of arthroscopy. He is the godfather of arthroscopy in Egypt, Africa, and the whole Middle East. Maybe he is resting in peace in a better place now. And thank you for the invitation from Dubai Shoulder Course and EGAA. And let's start with the topic, the AC joint. It's, as you all do, it's a plain synovial joint with intra-articular disc. There is no direct muscle action, but the joint moves passively at the end of motion, at the end of protraction, retraction, elevation, and depression. At the last 20 or 30 degrees, the joint moves. But actually the function, the main function of the AC joint is to transmit the forces from shoulder to clavicle and scapula, and it helps to keep the scapula adjusted to the thoracic cavity. And the most important thing about the magic about the AC joint is its stabilizers. We have the acromioclavicular ligaments. The most important are the superior and anterior ligaments. Maybe the posterior and inferior helps in the stabilization to a limited extent. But the most important of all are the coracoclavicular ligaments, namely conoid and trapezoid. The conoid is a posteromedial ligament. It is about the center of the ligament is about 4 millimeter 40 millimeter from the lateral end of the clavicle and in a position more posterior, as you see here. While the trapezoid is the anterolateral ligament, it's almost at the center of the clavicle, not posterior as the conoid, and it is about 20 millimeter from the lateral end. We know all Sir Rockwood and his famous classification, type 1 and 2, maybe type 1 and 2, there is no problem. Type 3, when all the spectrum of the ligaments are torn, so maybe the patient needs the surgical intervention to fix this problem. Type 4 as 3, but the AC joint or the clavicle is dislocated posteriorly. Type 5 is as 3, but the superior migration of the clavicle is more than 100%. It is completely off-end. And type 6 is the inferior, either subacromial or subcoracoid variants. Maybe recently there is a modification of type 3 that into type 3A with vertical instability only, which can, the essence of this sub classification is to guide the treatment. So type 3A with vertical instability only, maybe it is wise to do conservative treatment, and type 3B with vertical and horizontal instability, this may need surgical intervention. Maybe I have also a subdivision of grade 6. It's almost my clinical experience, because I experienced it sometimes, this associated avulsion fracture of the inferior part of the clavicle with the ligament. As you see here, the clavicle is subcoracoid, and the crater of the bone chips of the avulsed CC ligaments or coracoclavicular ligaments. Actually, the problem with the AC joints dates before Christ. When Hippocrates had his dictum, there is no impediment, small or great, will result from such an injury, and there would be a tomification or disfigurement for the bone that cannot be properly restored to its normal situation. Maybe his dictum is a bit right, as there is no joint in the body that has been treated in such different ways. All these are surgical interventions and procedures done for to fix the problem of the acromioclavicular joint. All these, maybe more than 100 surgical operations, but we can classify them into either AC-based operations, either repair, hardware fixation with screws, with K-wires, with intramedullary pins, with plate and screws, with hook plates, or reconstruction of the acromioclavicular ligaments, or arthrodesis and excision, as in Weaver done. But actually, these AC old based procedure has high rate of failure. While the newer or a more recent one, the coracoclavicular based procedure, either repair or fixation or reconstruction using Bosworth screw, using soft tissue graft, using tight ropes. But although it has better failure rates, but it has still suboptimal sometimes results with loss of fixation, pain, hardware break, migration, infection, fracture clavicle or lateral end of the clavicle osteolysis. The secret of challenge of the acromioclavicular joint is that both ligaments are important. The conoid is important for anterior and superior loading. The trapezoid is important for posterior loading. And the acromioclavicular ligaments, although they had a little, limited deal with the stability, but still they have important role in the horizontal loading. So here comes the our hypothesis with the combined acromioclavicular and coracoclavicular reconstruction that can lead to a satisfactory clinical and radiological outcome with less recurrence. And we proposed a trial, a prospective case series with more than 100 cases. We operated on type 3, 4, and 5 type of injuries. And the patient is put in a beach chair position with a 5 to 6 centimeter direct incision over the distal third of the clavicle and acromioclavicular joint. And we exposed the acromioclavicular joint. We opened the ligaments of the capsule, and we opened the clavipectoral fascia distal to the lateral third of the clavicle to expose the coracoid. Then we do 2 millimeter drill holes at the conoid and the trapezoid points. Guided by the anatomical studies that studied the center of these two ligaments, almost as 2 centimeters for the trapezoid center and 4 centimeters from the lateral end of the clavicle. This is the right shoulder, and we are looking from the anterior aspect. Keeping the conoid at the posterior or 4 millimeter from the edge of the posterior border of the clavicle and the trapezoid hole at the center of the clavicle. And we only need the 2 millimeter drill hole, or 2.5 if you don't have a 2 millimeter drill hole. So it would be more than enough. Then we pass the number 2 vicryl through these holes, and we hook it around the coracoid base. Maybe this is the most tricky point of the operation, and actually it's difficult to have a picture of it, because you hook the whole coracoid with a clamp, 90-degree clamp or a vascular clamp to pass the vicryl suture. And once you have the vicryl suture hooked around the coracoid and into the conoid hole, then you can relay a fiber tape. Then we pass it through the conoid and the trapezoid hole. Then we tie both ends on the top of the clavicle. Actually, when I started with Dr. Izzat, this technique maybe 15 years ago, we used to use soft tissue graft. Then we shifted to the nylon tape. Then we shifted. I shifted recently to use the fiber tape. Okay. The next step is to do a 3rd and 4th holes. 3rd acromial hole from superior to anterior border of the acromion, and a 4th hole into the clavicle, 1 centimeter from only 1 centimeter from its free end, lateral end, from anterior to posterior. Then we pass the free end or the long end of the fiber tape into the superior hole, from the superior hole to the anterior hole. So this will represent the superior acromioclavicular ligament. And when it appears at the anterior end of the acromion, we pass it again from anterior of the clavicle to the posterior of the clavicle, okay, to tie it again over the other limb, which has been already sutured to the top of the clavicle from conoid and trapezoid limbs. So This is a reconstruction of the conoid, trapezoid, superior, and anterior AC ligaments. Then after that, we closed the acromioclavicular capsule, which we just opened over the tape with anatomical closure. Here is a representation. This is the first passage, the conoid, then around the base of the coracoid, then trapezoid. We tie them together. We pass superiorly to the acromion, anterior to the acromion, then in front of the acromioclavicular joint, then back and tie them with the other limb of the same tape. We only use one tape. Then we put a sling for 3 to 4 weeks with supine passive range of motion, deltoid and elbow exercises. Phase 2, we remove the sling and we start active range of motion. And phase 3, we start full range of motion with sport accelerated program. Actually, the clinical results of the VAS and the activity of daily living, range of motion, and the American shoulder and elbow score and constant score, both, all of them were statistically significant. As you all see here, these are the numbers. The radiological results also are quite satisfactory and successful. As you see here, only 1 millimeter at 10 years, 1 millimeter only difference at the superior and posterior displacement. As you see here, this is the Zanka view pre, and as you see here, this is the axillary, and this is the post, this is pre, this is pre, and this is post. As you see here, this is the post X-ray, and only you have tiny holes, maybe will not be discovered by the patient or other radiologist. The advantage of the technique is that already we had a long follow-up, more than 10 years now. Maybe the whole unit in Ain Shams University are doing this procedure. It addressed all the injury components, the acromioclavicular and the coracoid-clavicular, with almost 98% success. There's no hardware, so there is no risk of osteolysis and hardware breakage. It's mini invasive, actually, only 5 centimeter, maybe collectively it's about 3 portals, arthroscopic portals. So the rehabilitation is accelerated. It's very economic. You use only one tape, either nylon tape or fiber tape, and it is safe because you only drill very small holes, 2 millimeters, so there is no risk of fracture. Maybe the disadvantage of the study, it lacks a control group and it needs a biomechanical verification, but it is maybe a long way ago, maybe 10 years or 9 years ago, I published this article, the midterm results in arthroscopy, and it is very well accepted in our unit in Ain Shams University. So the conclusion is that combined anatomical reconstruction of acromioclavicular and coracoid-clavicular ligaments using tapes provide overall 98% satisfaction and 94 radiological reduction, and only 0.9% recurrence. It's one case recurrence, actually, because the patient didn't follow the rehabilitation program. Thank you. I hope everything was clear in the talk.
Thank you, Dr. Sobhy. That's very clear. Thank you. So without further ado, I will move on to the next speaker, Dr. Usama Saleh from Dubai, UAE. Please share with us your screen and talk to us about arthroscopic AC joint acute reconstruction. Thank you.
Thank you so much, Ali, and thank you for Dr. Sobhy for his nice presentation. I will complete the presentation with the arthroscopic way to manage the AC joint in the acute setting. So we have to come to know the anatomy with Dr. Sobhy in details about the structure which is stabilizing the AC joint. But what I want to stress on the part of the anatomy is the stability of the AC joint is not coming only from the CC ligament. The stability of the AC joint, it comes from three important structures. And the first message today is when we repair or when we manage the AC joint, we have to address the three important structure which is stabilizing the AC joint. It's the CC ligament, the conoid and trapezoid, and the acromioclavicular ligaments and acromioclavicular capsule. And the third structure, which is the deltotrapezial fascia, and it's very important stabilizer in the dynamic setting. So when we deal with the AC joint, again, we have to address the three structures. The second point, which I want to stress today, is the radiological finding of the AC joint. And we all know that when we take an X-ray for an AC joint separation to see which Rockwood type, we do an AB, axillary, and Y scapular view. The axillary view is very important view to see if there is any posterior displacement of the distal end of the clavicle or not. But guess what? This axillary view is usually a static view. And when we move our shoulder and when we move our AC joint, it's a dynamic, situation, and we have to address that. And because of that, we start recently doing Alexander view for all our patients, especially type 3 and type 2 AC joint separation according to Rockwood classification. What is the Alexander view? It's just an Y scapular view, but the arm is usually in cross-body adduction to do a stress on the AC joint to see if there is any dynamic posterior translation or not. This Alexander view is quantifying the dynamic posterior translation. So it's usually differentiate between type 3A and type 3B, and it can pick up some of the type 2, which looks in the X-ray as a type 2, but when you do a stress view, usually the distal end of the clavicle move posteriorly, and this is an indication of instability. So message number 2, radiologically, you have to start doing Alexander view for all of your patients, especially type 2 and type 3. MRIs been recently one of our routines in the pre-evaluation of the AC joint. The classification, we are all familiar with the classification, and we are all familiar with the operative consensus on the three last types, 4, 5, and 6. And we know the bad type, which is type 3, and there is no consensus till now. What I do usually in my practice for type 3, I usually offer the patient a surgery in some situation if he is a heavy worker, if he is a throwing athlete, if he is a sports active patient. And of course, when I do dynamic Alexander view, when I do dynamic view, and I found that there is a posterior translation of the distal end of the clavicle, that's for me type 3B, and I usually offer the patient surgical intervention. There is no scientific consensus on that, but that's what we're doing in our daily practice. And I don't know the rest of the faculty, they do agree with that or not. So the surgical technique, I believe in my presentation, I have to answer two questions today. The first question, why I do it arthroscopically, and the second question, how is the technique, how I do it. So if you look at the literature and see how many described technique to manage the acute AC joint, you will find literally more than 100 described technique. And that's mean there is no one specific technique which is marvelous and all the people have a consensus on this technique. But to be honest, there is a certain techniques, you shouldn't do it and you shouldn't try it, although it's been described in the literature like this one, this screw. Why I do it arthroscopic assisted? I'll start my presentation with this. This is a 4 patient. I just did AC joint repair in the last couple of months. That's the left shoulder. Look at the anterior-inferior labrum in this patient. That's another patient. Same left shoulder, posterior-superior labral tear. That's another patient, right shoulder with anterior-inferior labral tear. And that's another patient with partial thickness supraspinatus tendon tear, articular side. You can argue with me that this patient, yes, so what? It's a minor injury and we can ignore all of this concomitant injury. But guess what? I'll show you another patient, type 5 AC joint dislocation. Look at the long head of biceps and the superior labrum. And I'm pretty sure if you ignore this kind of injury, the patient will not be satisfied. The results will be completely inferior. And you can easily miss this kind of injury if you do it an open technique without any arthroscopic assessment. And if you go to the literature and see what about this concomitant injury, you will find that many articles is being published on this subject, and the percentage is completely different, but at least this is one of the articles. 53% of the patient who have a high-grade acromioclavicular joint separation, they do have a concomitant glenohumeral pathology. It could be in the form of labral tear, long head of biceps tear, or subscap, partial thickness, or upper border subscap tear. And 22% of this patient, they do need a repair procedure for this glenohumeral pathology. Another article published by Marcus Scheibel showing in his series that 30% of the patient with acromioclavicular joint separation, they do have a concomitant injury. Meaning that every 10 patients, you at least have a 3 patients, they do have a concomitant injury, which you easily can miss if you do it open, not arthroscopic. Another article showing that up to 40% of the patient with AC joint separation, they do have intra-articular concomitant injury. And I think because of this literature and because of this videos I show it to you on the arthroscopic finding of the patient with a glenohumeral, with the acromioclavicular joint separation, you have the answer now why we tend to do it arthroscopic. The next question is the surgical technique, how we do it. I usually do it by viewing from the posterior portal, and I have 2 anterior portal, one in the mid-glenoid portal and one anterosuperior lateral portal. I start my surgery with an open incision over the AC joint. Anyway, I have to address the AC joint ligaments and AC joint capsule. I have to repair it by the end of the surgery. So I tend to start with this one, doing a very good reduction under vision and under X-ray control. Then I apply 2 K-wires, and I usually keep this K-wire away from the area where I will next put my tightrope. Then the next is 3 portals, as I said, viewing from posterior, working from 2 anterior portal. Let's start with viewing from posterior, mid-glenoid portal, retrieving the cannula back and start taking part of the rotator interval. You can see here down is the subscapularis, long head of biceps. That's a right shoulder, and that's the rotator interval. Try to take apart from the rotator interval, which allowing you to visualize the base of the glenoid. You don't have to take or to release or excise the whole tissue of the rotator interval like we do in adhesive capsulitis. Just keep going back and to the medial until you expose part of the base of the coracoid. Keep using the radio frequency as a blunt dissection and to feel the base of the coracoid, which you are targeting. And once you see a small part of the coracoid, like we see right now, here to go, that's the base of the coracoid, starts to appear here on the field. Then stuck to the bone and keep going medially on the undersurface of the coracoid, and keep going anterior until you see the conjoint tendon to know exactly where is the tip of the coracoid. The next step, after I get some decent exposure of the coracoid, I just put a needle to mark the anterolateral portal, portal, where I use it also to expose the base of the coracoid and use it as a working portal and to retrieve the stitches later on. The trajectory of this portal with the base of the coracoid is very nice. It's better than the mid-glenoid portal. At this stage, usually I'm shifting from the 30-degree scope to the 70-degree one. That's why I keep viewing from posterior. I guess the people who doesn't have this option of getting 70-degree scope, they can shift their viewing portal to be from the anterosuperior lateral and keep working from the mid-glenoid portal. But since I do have this option of 70-degree scope, I keep my viewing posteriorly. I can see clearly here the base of the coracoid with the 70-degree scope. And once I feel that there is a good view and good exposure of the base of the coracoid, the next step for me is to inserting the guide. There is a specific guide from Arthrix for that to protect the wire from going down to the lung. And the next step, once you fix your guide down, you go up and fix the drill here on an average distance of about 3 centimeters, or as I will show you later on, there is a percentage which is about 20% from the length of the clavicle. Then my guide should be in a position where it should be completely perpendicular to the base of the coracoid, to be in one line like this. Then I will go again, do the drill. I started first, when I do this technique, I was using the 4.5 cannulated drill from Arthrix. Then I moved on to use only the guide wire, which is 2.5 millimeters. And since everything is fixed with my K wires, I just put straight microsuture lasso through this one. And I have the advantages now of doing very small drill hole, very small tunnels, which is 2.5 millimeter only. Then getting the Nittilon wire and shuttling my suture, which is usually 4 tapes, and then clean around the dog bone button to see that it's completely resting on the bone and there is no soft tissue in between. Sometimes I start using a cannula. That's another right shoulder. It's the same technique exactly. Sometimes getting a cannula and feeding it with Kingfisher, and the button here it is resting. The rest of the surgery is completely fine right now. Just you have to go to the clavicle and tie down your knots, and it's done. But as we said, from the anatomy, it's not only the coracoclavicular ligaments, the acromioclavicular ligament is very important stabilizer. And when you look at, if you look at your cases, and you will find it's always the acromioclavicular ligament is being ripped off from the distal end of the clavicle. It's never been detached from the acromion. So for me, I find it's very easy to reattach it again to the distal end of the clavicle with the transosseous suture. I use a heavy needle, epi bond, and resuture it back to the distal end of the clavicle. And this one is still working with me very well. Sometimes I use the needle, the same needle, and take some stitches from the bone here and go through all the bone in the acromion as well. That's the second structure we have to address is the acromioclavicular ligament and acromioclavicular capsule. The third one, which is also very important one, you have to tightly close the deltotrapezial fascia because it's a very important dynamic stabilizer of the AC joint. There is some important consideration you have to take in consideration with when you deal with the acromioclavicular joint, especially with this technique, is the coracoclavicular distance. And when you measure your coracoclavicular distance post-reduction, compare it to the other one, you have to be within 25% difference from the other one to get a good results. The other one is the clavicular tunnel ratio. Where exactly you have to put your clavicular tunnel? Is it here, 1 cm or 3 cm? There is a ratio for that. When you measure the whole length of the clavicle from the sternal end to the acromion end here, your clavicular tunnel should be in a ratio of about 20% from the whole length of this one. And this is according to the according to the anatomical studies. The third one, which is a very important one, but I think this is could be a problem with Dr. Sobhy when he's doing it open, but the technique of doing it doing it arthroscopic guided, since we drill transclavicular and transcoracoid, it's not a big deal. It's called the clavicular tunnel anteroposterior angle. It's meaning that a straight line in the middle of your clavicular tunnel, a straight line in the middle of your clavicular tunnel, they should be parallel to each other and there is no major angle. If you have a major angle, this is a prediction of failure and less satisfactory outcome. Why it could be an issue? Because in open technique, you drill the clavicle you drill the clavicle separately from drilling the coracoid. But in our arthroscopic technique, usually we drill both of them in one line, as you saw before. The other important consideration post-operatively, you have to look at your distal end of the clavicle. Posterior translation is a very, very, it carries always a very bad outcome. And you have to address this. That's why I usually start by opening small incision there, reduce it on both the coronal and the transverse plane, and put a K-wire and proceed with the rest of my surgery. Going central in the coracoid is a very important consideration as well, and we cannot ignore that. If you go eccentric like I did in one of my early cases, you will end up with failure of fixation like this one. Last but not least, what is the predictive factor for inferior results? You have to know which patient is usually doing very bad or which technique is usually having inferior results. Patient age is more than 50 years old, they usually carries a bad outcome. If you do your surgery after 10 days from the injury, that makes you in a situation that the outcome is not satisfactory. Post-operative reduction quality is very important predictive factor, and stabilizing the CC ligament only is inferior to stabilizing both the CC and AC ligaments. That's some x-rays, and that's some of my patients post-operatively. They do very well if you do them in a correct way and in a good indication. So I have 3 important messages to you today by the end of my presentation. When you deal with an acromioclavicular joint separation, you have to address the 3 important structures, which is stabilizing the AC joint. These 3 important structures are the coracoclavicular ligament, the acromioclavicular ligament and capsule, and the deltotrapezial fascia. Dynamic posterior translation is very important in the judgment and very important in the decision making, and you can achieve this only if you do an Alexander view. And please, when you do an open, you have to think about the concomitant injury. when I start to do this technique, I usually do it open, but at the same time, I do a quick diagnostic arthroscopy before starting with my open procedure. Then time by time, I moved on to do it all arthroscopic. Thank you so much for your attention.
Thank you, Dr. Usama, for this nice talk. It's very conclusive, very clear, very nice, very seductive technique, of course. We have to move on. Thank you very much for this talk. Please, Dr. Usama and Dr. Sobhy, if you can answer some of the questions in the Q&A panel that we cannot take, because there are some more. If you can just type the answers, it would help our audience, because I don't think I can take all the questions today. So it's 11:30 or 10:30. So please, we move on to the last topic today, Dr. Machani, who will tell us how he manages adhesive capsulitis. Please, welcome.
So I'm afraid I won't be able to tell you that this is the best way to treat, but certainly this is most widely accepted current practice in Western settings and also most part of the world. So about 150 years ago, it was the Duplay who first named it as periarthritis scapulohumeral, and it was Codman in 1934 and termed it as frozen shoulder. And 1972, Neuweiser called it as adhesive capsulitis. But I like the best is Zuckerman, who says was one of uncertain nature. Frozen shoulder, this is a class of cases which I find it difficult to define, difficult to treat, and difficult to explain. So true. It is incredible that just a decade ago, a frozen shoulder was so commonly overdiagnosed, misdiagnosed, nature ill understood, pathology unexplained, and patients with the condition were subject to misinformation, therapeutic nihilism, quackery, and neglect. So have things changed? Have we understood the pathology better? Do we have better treatment options? And I think we have more questions than answers than before. Epidemiology, the incidence is 2%, and we all know it is rising. It's a common in fifth decade, more common in female patients. It's bilateral. The literature says 6 to 30%. In diabetics, particularly in type 1, 70% of them will have frozen shoulder, and 50% of the diabetics will have bilateral symptoms. Recurrence, fortunately, very, very few case reports. Pathology, it's basically a synovial inflammation causing capsular thickening, fibrosis, adherence of a capsule and to itself and to the humerus. Involvement of different structures lead to different restriction of movement. And Lundberg was the gentleman who first studied as primary and secondary. Surgical findings, Codman said that most of them had synovial inflammation. Neuweiser found thickened contracture. Near identified it's a CHL, which is a shortened and thickened. Ozaki clearly mentioned the major cause of restriction of movements was contracture of the coracohumeral ligament and the rotator interval. And Bunker in his 25 patients of surgically treated for frozen shoulder, he found the main pathology was in the coracohumeral ligament. So in essence, we are pinning the point towards interval and mainly a coracohumeral ligament. Associations, you can name it. Everything is associated. So the list is endless. Codman, the criteria are very specific. He said these criteria have to be met if you want to term it as a frozen shoulder, which are insidious onset. And the pain has to be global. The patients usually complain that they can't sleep very well on the affected side. And the movements are extremely painful and incomplete forward flexion and external rotation. And the x-rays should be normal. So these are the criteria in a typical frozen shoulder patients. What is the natural history? I mean, we all know that there are a few stages, some call it as 3 and some as 4 stages. But in essence, it's a freezing or early inflammatory, frozen 4 to 12 months, and thawing is maturation and contracture. There is obviously an overlap of these phases, but somewhere between 18 to 36 months, and some recover very quickly and some don't. So most important thing is diagnosis and the history, and the diagnosis is by exclusion. The differential diagnosis you think of is obviously in patients who have glenohumeral arthritis, and X-rays should be normal. And the discriminating stage 1 disease from other pathology can be extremely difficult, especially in type 1, in the phase 1 of adhesive capsulitis, and also patients with early impingement. The findings are very similar. You have almost full range of movements, positive impingement signs, pain global. So it's extremely difficult to differentiate between these two conditions. Ultrasound may have a role. It might show decreased volume, but MRI scan, it'll rule out the other structures. That's mainly a reason why you get an MRI scan. Otherwise, it's a clinical diagnosis. And thickness of more than 4 millimeters of the capsule could be more significant and relevant in diagnosing frozen shoulder. So treatment. So how do we approach? I mean, we can let it heal. We call this as supervised neglect. Stretch it out by physiotherapy. You can break the contracture by distension or hydrodilation, or manipulation and anesthesia. Or you can excise the contracture, open versus arthroscopic. Treatment, optimistic surgeon, they will all get better in 2 years' time. Pessimist, they will never completely get better. And we all are somewhere in between, majority of us. Treatment in favor of surgery, Codman said, in favor of no surgery, even the most protracted cases get better in about 2 years' time. Rockwood said 46 out of his 50 patients were normal, and Reeves 60% had some restriction of movements, but only few were handicapped with this restriction of movements. Surgeons who were in favor of surgery, Simmons said, complete recovery is not my experience. It is erroneous to believe that in all instances, restoration of function is attained. Schaffer said 50% of his patients have some residual pain or stiffness. So you can see, there are different surgeons and different surgeon groups. The options available are distension orthogram, the level 2 evidence that distension with saline and steroid provides some short-term benefits in pain, range of movement, and function. However, it is uncertain whether it is better than any alternative interventions, or if it actually reduces the incidence of intervention. So it's a distension orthogram. It's a fine line between a capsular stretching and rupture. There are many papers now are coming. I don't do capsular rupture. I do capsular stretching. I mean, I find it extremely difficult to identify when I'm doing this procedure. How do you differentiate what is stretching and what is actually a rupture? Is it volume dependent? I don't know. The other debate is, should it be done by a radiologist or a surgeon? Should it be done under X-ray control or ultrasound guided? Or do you want to do with or without orthogram? So we'll talk on that a bit later, or how I do it. Treatment, if you talk about manipulation, there are two main techniques. Nevisor, when you block the scapula, but his main thing was he used to keep the arm in external rotation, and abduction was his primary attempt to manipulate, followed by flexion and internal rotation. As compared to Bigliani, his was forward flexion, which was mainly his way of dealing with that, and followed by abduction and external rotation and internal rotation. So we all have our different techniques. The main thing is you control the scapula and you do a controlled manipulation. Whether I do it manipulation or anesthesia or not, that's a different matter. So non-operative literature, 50% return to normal, more than 70%, 90% return to normal. But some papers say that all the patients improve symptoms, but it's not good enough. Release, if you're doing arthroscopic release or open release, when and which patients? Do you want to manipulate first and then do arthroscopy, or you want to do arthroscopy first and then manipulate? These are all the questions which are done differently by different surgeons. Bigliani, he manipulated first, followed by arthroscopic release, and he had 50% excellent and some poor patients. And in his paper, if you look back clearly and in detail, there's 15 to 20% of patients who had capsular rupture associated with the glenoid labral pathology or some sort of rotator cuff tears as well. So I know the answer to that question is I would not manipulate before I do an arthroscopy. And PSL, he had better results when he did arthroscopic release before manipulation. So arthroscopic release in particularly diabetic patients, not a big number. Average symptoms before 12 months had a decent outcome in these kind of patients. One question I always ask to myself, and unfortunately I haven't found an answer. I'm sure the panelist will be able to answer this. Does glycemic control in diabetics have any influence in the outcome of frozen shoulder once the frozen shoulder has already set in? Mini open is also done by some surgeons, but it's not something which is now routinely done. So how do I treat them? So I thought I'll just play this, it's too late. I don't, if it works. Okay, so it doesn't. So how do I treat? So non-operative physiotherapy is something that I am not in favor, especially in the first stage. Patients are in acute pain, severe pain, and they're going to go into more pain and more stiffness. And I find it extremely torture to the patients. They always come back and tell physio made it worse, it's not getting better. I've had 30 sessions of physiotherapy, it's not help. But I don't know, I just can't understand how you can stretch in somebody who has got so much of contracture without putting them through pain. That's my opinion. I don't approve of it in the initial stages. I do inject sometimes. Sometimes patients are in severe pain. They don't get better with codeine or simple anti-inflammatory, and if they don't want to go for other modes of treatment, then I do inject, and I don't think it works very well. Hydrodilatation is something which I have been doing it more often these days. I don't do it in diabetic patients. It simply doesn't work. And the best results are when done within 6 months, but better if it's in first 3 to 4 months of onset of symptoms. So this is my protocol, patients in semi-big chair, sedation. I do it from posteriorly under X-ray control. You infiltrate skin and up to the capsule with lignocaine first, and then keep another syringe ready with the cannula and some long-acting local anesthetic. And I keep about 100 ml of saline separately. I don't know why this is a nice video which isn't working, but it is working. So I can see that the syringe is actually in the joint, and you can see the saline coming back into the syringe, confirming that the needle is into the shoulder joint. And then once I've done that, I inject up to 60, sometimes 80 saline, and then finish off with the cannula and long-acting local anesthetic. I don't manipulate. After a week, the patients usually start their own movements, and if they're better with pain, then I start physiotherapy after that. So how do I treat the patients who come with adhesive capsulitis? I think the bottom line is you have to treat the patient and his needs. The patients like drivers, teachers, and who have hobbies like playing tennis, and diabetics, if they don't do well in first few months, they can't wait for 2 years, 3 years, and then they do request to do something to hasten the recovery. And I think this is where the decision comes. I mean, we've tried hydrodilatation. If they're fit into that, we do that. Otherwise, I don't do routinely manipulation. In fact, I've not done for a very long time, and I do arthroscopic release under GA and regional block. And it's quite nice to see the patient having good range of movements after the surgery with the regional block, I go to the room and tell, look, you got such a good movements there. And then they get the self-motivation. Yes, obviously it's very painful, but no pain, no gain. So I do arthroscopic release. And most important thing is the most important structure is the coracohumeral ligament. It is important to understand that when you put the scope from the back and then you got an ortho wand or a shaver, whatever you use, the first thing you do is interval, then the capsule. And then important to remember that the coracohumeral ligament is the extracapsular. Then it's important to, hopefully this works, yeah. So that is the, clearly that's the thing that you need to, there's a capsule, and then you need to be careful and make sure that you release the coracohumeral ligament, which is very, very important. And the moment you release the coracohumeral ligament with the gentle external rotation, you can see the movements coming back very nicely. The first thing you get is almost full range of external rotation. And again, this is a cadaveric arthroscope showing, hope it works again. I didn't. So if you got time, I mean, just scenario one, I mean, you have a 43-year-old female, she's diabetic, housewife, 7 months history of pain and some stiffness. I mean, clearly she's a low sedentary worker. For this lady, I will explain education is important, the natural history. Although she's diabetic, there's still a good 90% chance she will recover. It can take 2 years or 3 years. If she can put up with that, then I do offer her non-operative treatment and I don't interfere. Scenario two, if it's the same female, if she's a teacher and if she's diabetic and then she needs her arm, she can't wait for 2 years. And this is why I'm stressing that patient needs are the most important one that will dictate us what we actually have to do. For this patient, I will offer arthroscopic release. And again, this is not an uncommon scenario. We do come across somebody falling off a trivial fall. They initially have some pain, now stiffness, treated with physio injection. They don't get better. And it's important then to remember, what it's better to rule out anything underlying. Do an MRI scan, which shows full thickness tear. What do you actually do for those patients is something we can discuss later. To conclude, it's a very, very common and associated with many conditions, very common in UAE. I'm sure it's likewise in Asian countries too. There is no definite protocols of treatment, to be honest. The patient needs is the one that dictates specific treatment. And there is now increasing evidence suggesting surgical intervention may be beneficial for early recovery in particular patient groups. So, I mean, I do apologize for the inconvenience. I don't know what happened there, but we'll take some questions now.
Thank you, Dr. Machani. Very clear talk. No worries. We all face this technical issues. At least it's done by the end. It's a good job. Nice presentation. Very clear thought. So please have a good night. Thank you for joining us. Any comments from the co-panels?
Thank you, guys. Thank you very much for the invitation.
Thank you so much.
Thank you, Usama, Dr. Ali. Thank you very much. And thank you, Dr. Machani.
Thank you all. Thank you, Dr. Usama. Excellent topics and excellent discussion.
Thank you so much. Good night.
Thanks, Dr. Adil.
Good night all.